You know, Andy, in our discussions, you and I often agree that sleep is very, very important, at least stable sleep is for the bipolar individual, and it can be as potent as most of the medications prescribed today. Can you talk some about that and help us understand why that's the case?
Certainly. We really don't know exactly why, but it's pretty clear that sleep is crucial. We know that disturbances in sleep are one of the hallmark signs of the illness, that people, when they're hypomanic or manic, they don't need as much sleep. They really sleep for 2 or 3 hours and they feel completely rested and energized the next day. So there's clearly something going on. And there's even some suggestion that the genetics involved with it are similar to the genetics in migratory birds who, stay up for hours and days on end as they're flying cross country, and that there may be a connection there. And so that there's something going on where our normal sleep cycles are disturbed if we're bipolar when we become hypomanic or manic in particular, and we truly don't need but 2 or 3 hours of sleep. We also know that people can precipitate an episode by just flying across the ocean. If they fly a few too many time zones and create a little bit of jet lag, it can provoke an episode of hypomania or mania or depression. So there's clearly something involved in the sleep cycle that is a part of the illness. Where that comes into play with treatment is, you and I both know, if we can get our students, our patients with the illness, to have a normal sleep cycle, it's like a mood stabilizer. And so trying to have them do good, what we call sleep hygiene, good behavior around sleep, trying to get up at the same time 7 days a week, trying to go to bed close to the same time, shooting for 8 or 9 hours of sleep, which is what that age group requires. If they're having trouble sleeping, taking medications that will help them get to sleep so they don't get into a cycle. That if they do that, if they have good sleep, that it really does make a significant contribution to their stability. Similarly, if they work a job that ends at 11 or midnight, which we've all seen, that it very quickly slides into not getting into bed till 1 or 2, then it's not getting into bed till 3, and then it doesn't take many weeks that they're starting to get depressed or they're just starting to get off cycle. So I encourage all of my patients not just to have a good sleep cycle, but not to do the things that we know disrupt the sleep cycle. I don't want them working 3 p.m. to 11 o'clock job. I absolutely don't want them working as a night clerk at a local hotel or motel, which is manned pretty much by students.
What about the use of caffeine and energy drinks, which we find to be very prevalent in the university population, particularly when they're up studying late at night?
Well, it's like substance abuse. I'm begging and pleading with them not to do it, and asking them to avoid the kind of things that would keep them up beyond 11 o'clock or midnight. I ask them if they can, and you know how often this is possible, is to try to have a midnight rule, that they really want to be in bed and asleep before midnight, to make midnight sort of the bewitching hour. And I ask my patients to pick a time, sometime before 9 o'clock in the morning, to get up every day, 7 days a week. And we now have some good evidence that if you can get up and get morning sunlight, combination of good sleep and morning sunlight will be like a mood stabilizer, and that will help create stability for you and reduce misery, reduce depression, reduce even some of the mixed episodes. And so I want them to start thinking about sleep just like they think about their Lamictal or their Tegretol. It's a mood stabilizer, and to have them start thinking about a choice. In other words, do I want to have good sleep as a medication, or do I want to take a pill that has side effects like weight gain? Do I want to have go to bed at midnight and wake up at 9, or do I want to when I get off cycle a whole lot, have to take a medication that is going to make me overweight or is going to make me thirsty all the time? So I try to get them to think of it as a choice, which will allow them to think about the possibility of taking fewer medications and achieving stability. But in a university population, it's tough.
I often see the learning curve with these students where I may see them in their first year, and at least here at UVA, all first years live in their residence halls. And so they're up till 2, 3 in the morning because they're in a residence hall, it's noisy, other students are up. But if they're bipolar, they know that that becomes a kind of, it's detrimental for, well, they don't know that in their first year, but they find that their irregular sleep is detrimental for them. And I may see that same student in their third or their fourth year, and here they are off campus, maybe living on their own or with one roommate, and they're getting good sleep hygiene. You know, they're going to bed at decent hours and they're getting up at decent hours, and they really are living in a much healthier way because they've learned over the course of 2, 3 years that that makes a huge difference. And when they get that, I always feel more assured.
Yeah.
I know that they're going to be safer.
And if they don't see the connection, we want to point it out to them. We want to say, when they say to us, gee, I've been really doing well the last couple months. I say, well, it might have something to do with you got decent sleep for the first time in a couple years. And I think it speaks to the broader issue of learning by experience.
It brings to mind a student I recently saw who began their student teaching this semester, right? This is the first time in their progression of school that they had to get up and be somewhere at 8 o'clock every morning. Well, they found they couldn't do that if they were up till 3. So they started scaling back their bedtime. So they're in bed at, 11 or 12. Now they feel kind of out of sync with their friends who are up, but they're doing it. They're going to bed, they're getting up at 8, they're going to work, and they're feeling better.
And did they see the connection?
Yeah.
Yeah. Well, and I think it gets to that. What we want to do is put our patients or encourage them to give themselves the experience of these things. You're right, we can't force it on them, but if we can encourage them to give themselves an experience of it, that will get through to them. Because I think realistically that's how we learn, not by what people tell us, but we learn, we test it for ourselves.
We learn
by
because
experience.
We find it's good for us.
Right.
Right.
And that's what we want to do. And so I try to get them to at least, I ask them, I will say, look, humor me. Just try it for a week. Just try it for a week or two, see what you think. If I'm wrong, okay. But just, humor the old man here. Try it. And particularly if they are living in a place where they can get it, I think pretty quickly you're right. They'll see that it really contributes to a sense of well-being, and then it makes it a little bit easier to refuse staying up